For this room, but for the...
Yes, that's right.
Good. Good morning.
Good morning.
My name is Marta Argueta, and I am a professor at the University of South Alabama in Mobile. You can tell by my accent, I am originally from South America, Peru, and I have been in the United States 30 years this year. 15 of those 30 years, I have worked at the University of South Alabama, and I was one of the founding members of what we call the Center for Healthy Communities, which is the University of South Alabama College of Medicine community engagement, let's say, enterprise. We are not a big enterprise. However, I think we can proudly say that over the 15 years, we truly established a strong platform for community engagement at the University of South Alabama. And in fact, that's the reason why I am here, because the University of South Alabama, aside from being a partner of the UAB CCTS, it's also one of about 6-7 partners in the Regional Community Consortium, which is the Regional Community Engagement Consortium, which is one of the arms of the UAB CCTS too. So we have two ways in which we are connected to UAB. So the topic that I am going to speak about is my life, is what I love to do, is what I am interested in. However, it is not, it is certainly an interface, I see it, between science, humanism, and something that engages us not only as scientists, as investigators, but also tests a little bit our fundamental roots as investigators and as people, trying to live their lives with a very, with some sort of sense and direction. So although there are very definitive principles to community engagement, there are definitions and specific issues that I want to introduce to you that we can evaluate as scientists. I'm also going to test a little bit beyond that as to why do we do science, how do we do science, what's the ultimate purpose of our work as scientists. So let's get started. Now, I want to show you, well, this is basically what we're going to be talking about. As I said, there is some specifics that I need to convey to you. But we're going to start by looking at what you are, because you are a cadre of scientists within the UAB CCTS, a Translational Science Center. And this comes right from the website at UAB. So the CCTS is here to sharpen your science, okay? If there are any needs that you have as investigators, the CCTS is going to cover those needs. They want to do their job as best as possible, but look at the last sentence. Your science should be inspiring, and we can help. So the very first question I have for you is, what inspires your science? When you come to work every morning, and I know it's dreadful sometimes in the laboratory with patients, all the administrative things you have to do, all the many little tasks of your day, they should amount to something, don't they? So can any of you tell me what inspires your science?
Patients.
Patients? In what way?
I specifically take care of cancer patients, so seeing them healed or at least improving their quality of life.
Exactly. So you can see every day that your work actually means something to a person, isn't it? That is a very direct way to see the results of your work. You see it on your patients every day. Very good. Someone else? What inspires your science?
innovation, the search for the unknown.
So it's more an issue of curiosity,
Yeah.
isn't it? It's more an issue of learning something and discovering something. Mm-hmm. Anyone else?
Making a difference.
In what way?
Well, I'm particularly interested in improving outcomes.
Improving outcomes in any particular area?
Well, so I'm in infectious diseases, and I look at hospital infections, so making our hospitals safer.
Excellent, yeah. That's one of a major thrust of overall public health in the past few years. And there's been truly major improvements, but we're still a long ways to go. Yeah. So, in thinking what inspires you, you have ultimate outcomes that you want to achieve. You know, a cancer patient is treated well and possibly has more survival. You find something new, something interesting that is important to science and that can answer a few questions. You are specific as to we don't want any more patients having inter-hospital infections. So what inspires you is actually the outcome, isn't it? The outcome of where you're going, what you're doing, what's the ultimate value of what you're doing. Okay, well, look at what the CCTS says the ultimate value should be. Okay, so to me it was strange in that the very first paragraph of this website is what I just showed you. CCTS is about you. But then they explain their vision and their mission. And if you take a minute to read it, and then tell me, from the point of view of CCTS as an institution that you are a part of, what is the outcome? What is the outcome? According to the vision and mission of the CCTS.
To address healthcare disparities.
And what are healthcare disparities? What is that?
Could be access to healthcare.
Differences. Disparity means a difference, isn't it? So different access to healthcare, definitely. Any major issues about why people have different access to healthcare? Do you have any idea?
Socioeconomic could be perhaps some social or what is it? Some kind of a barrier.
But socioeconomic possibly the biggest one.
Cultural barrier.
Cultural barrier between the system and the person, sort of. So the health disparity is the difference in the access to healthcare that people have because of sometimes their socioeconomic environment, sometimes because of the culture or the fact that they are a minority, not necessarily racial minority, but perhaps a rural minority access to care. Geography can be another determinant. Okay, so at the end of the day, you are here and your science should point to this ultimate objective, isn't it? As individuals working within the CCTS, you are, let's say, the living cells of the CCTS, but together it is expected that all of you will sort of confluence into an organism that can actually create equitable improvement and in health and healthcare delivery. I mean, when we speak of disparities, there's disparities in many areas. But specifically, what kind of patients or what kind of disparities is the CCTS trying to address? Do you see it there? What kinds of patients? Cardiometabolic, vascular, and cancer-related diseases in order to ameliorate disparities in these and other conditions. And who is your target population?
Minority.
Minorities? In where? Here in the
region.
In the region.
Southeast, yeah.
The CCTS actually has a reach of central southern Alabama, and actually through partnerships reaches into Mississippi, and I believe Louisiana too, because the Tulane is a partner. So now, you basically, as I said, are the living cells of the CCTS. However, at the end of the day, your work should help address these issues, the issues of health disparities, and specifically these diseases, and so as to be clear as to where are we going to measure your impact is going to be measured regionally, here and throughout the Southeast. So it's not a simple assignment, isn't it? So I think you never, perhaps this is the first time that you hear or feel the weight on your shoulders, because that's what you have to achieve. Actually, and that's why they say at the very beginning, we are here to help. We know this is not an easy objective. The CCTS is here to help you do your best science so we can achieve these results. The key here is that to achieve those results, there is indeed a lot of infrastructure that has to be put together, and UAB actually has a tremendous research infrastructure. However, that's not enough. Let's continue. Well, okay. So, as translational scientists, the idea is that your work is going to be, it's going to make a difference to improve the health of the United States, specifically for this CCTS, the Southeast region. Okay? So when you come to work, and you are inspired to do your work every day, indeed, the ultimate objective is going to be this idea that what I do today, what I do through the 365 the days of the year, and what I do throughout my years here as part of the CCTS should eventually improve the health. It's no longer just what I do today, and I close my lab or I close my office and go home. I have not completed my work until the health of the population that's entrusted to me is better. This is actually a major shift in the way we consider science. Because in the past, before translation became a usual verb, a usual part of our vocabulary, science was very much just for the sake of science. Just, this curiosity that makes us want to know or learn or discover just for the sake of the discovery. But now that has to go one step forward, and those discoveries need to be translated into something positive for the population. Does that make sense to you? So how do we do that? You know, we have all of our training, all of our knowledge, all of our capacities, and we can make our days be very exciting as we do our work. But how do we make this ultimate goal become very present in our work? I want to show you something. So you don't have this in your handouts, because I just wanted to sort of tease you a little bit. So I'm taking you to the CDC Zika virus laboratory, okay? And I want to introduce you to these three professors, Dr. A, Dr. B, and Dr. C, okay? And can you tell which of these three is a translational scientist? Just by looking at them. You can. They are all doing the same thing. We know they are all working with Zika virus, you know? Well, let's ask them what they are doing. And let's see if through their responses, you can tell who is the translational scientist. Let's see. Can you tell? That's Dr. C. Why? He has that ultimate goal in mind, isn't it? That's not to say that the other two scientists are not good scientists or anything. They probably are very well trained. They are at CDC anyway. But the idea is the mindset, and that is something that makes a translational scientist. It doesn't mean you're going to change your ways in the quality of your science. It doesn't mean you have to change your ways in the way you do your work. It means you have to have that mindset. That mindset that what you do should eventually translate into something very specific that is a value to the population that your science is supposed to serve. And this is a big shift. And the CCTS, the translational, the NIH Translational Science Institute is truly putting a lot of money into that shift in the paradigm. Because when I came to the United States 30 years ago, I didn't have that mindset. My thought was, I'm here to do good science. This is the best place in the world to learn and to do science. Let me just work on what I need to do. And yes, of course, I did publish. I had my, I had things that I can count for me, but I didn't have that mindset that at the end of the day, everything should amount to a real change in the health of the population. Luckily, I did learn about that, and luckily now there is a big push for people like you to start your careers with that mindset, not to learn it as you go, but to actually start with that mindset, with the idea that what you do as a scientist is not going to be really valuable unless that changes something in the population that you are trying to serve. And this is a big, big difference from the way we used to do science, in the 20th century. This is the 21st century. So it's not only necessary that you are a good scientist, it's also necessary that you work in such a way that the collaborative push of all of you translates into a benefit to the community. Does that make sense to you? Okay. Any comments? Okay. Well, in order to do that, that's where community engagement comes. And this is, again, completely revolutionary. We are PhDs, physicians, scientists, and to think that to achieve that ultimate value, we need to engage people who are usually, if we are talking about disadvantaged populations, low educational status, many times low socioeconomic status, people who are not like us in the sense that, meetings, memos, written communications with points 1, 2, 3, that's not their cup of tea. That's not what they do. They are concerned with surviving. They are concerned with where do I get good employment, where do I get enough money to pay my bills, where do I get a good lawyer to get my son out of prison. It's a completely different perspective. So, in a sense, our ways and the community ways are different. And here we are mandated, and I'll show you exactly where it is mandated that we have to do this, where we as scientists are mandated to interact with these people in ways in which probably we are going to have to change our ways. We are not going to have to, we cannot ask them to change their ways to meet with us. We actually have to change our ways to go meet with them. And embrace something that's a bit chaotic, meetings that don't last an hour, but last 2-3 hours, meetings where people interject their personal experiences and problems because that's what they experience, where people are going to always bring you to a practical level. Not so much the talking and, yes, it's very interesting, DNA and RNA are interesting, but how do I get my son to get good employment? How do I get enough so that my water bill and my light bill are not going to be cut? Do you see? But that's what's going to help us truly learn what they need and how our science can help them. And that is what community engagement is. And if you look at what is called the phases of community engagement, where you can place yourself as a scientist in any of these phases, the basic science, the early transmission of scientific concepts to human populations, then the clinical trials that bring your science into use in the real world with clinical patients. Finally, after having proof that something works, how do you make it be the usual in medical care? And even then, how does that translate into health of the population? For example, hepatitis C. We have strong and, it is clear there are guidelines of how you treat hepatitis C. However, people who don't have insurance don't have the same access as people who have insurance to the treatment of hepatitis C. So it's like your science hits a roadblock. As scientists, we are doing a good job. We are really discovering, making things work, but it's not getting translated into that objective of population health. And that's why, as you see there, in those later stages, community is essential. And it's not necessarily, perhaps I described to you what it is an underrepresented community. But community is bigger than that. It's also, for example, the political context of a country. It's the industry privileges, responsibilities, regulations that make those drugs be so expensive. It is many things. So as translational researchers, you are also asked to be able to meet and discuss and speak with many constituents. I have explained about the underserved communities because that's what I do work directly with. but you will have to also sit in meetings with laboratory industry officials and be able to, in a sense, advocate or make a strong case. How do we get this drug to the people? How do we make this drug be accessible to everyone? Because that is what's going to make population health be a reality. So community is really a very concept here. And before, we as scientists could only, would just have to sit in our laboratories or in our offices and do our work. But now, translational science requires that you are really multifaceted in your capacities, because you also have to sort of push the whole enterprise towards this population health concept. So this is the traditional way in which these steps of translational science have been depicted. However, it's not a linear process. This is what the Center for Translational Sciences at NIH depicts as translational science. So instead of being linear, start at 0 and end at 4, it is circular in that each and every step should inform the step behind, the step forward, and even the step at the end. So my question to you is, for example, your smartphones. We all have one. Can you think of anything that you would wish your smartphone to do for you that doesn't do now? Can you think of anything, any twist that you would want your smartphone to have, any capacity that it doesn't have now? Or are they perfect? I tell you the one that I would want. I would want for my smartphone to only tell me when my husband and my kids are sending me a text, but not when anyone else is sending me a text. I think that capacity exists, but either I don't know how to access it, or it's not there. I would love for my smartphone only to give me, only ping me when I receive an email from my boss, not from the 30 other people that send things that are just communications. So as an end user, that's what I want. Should I be consulted on that? Let's see. Should I be consulted on what I want at the end of that? Where would it be more effective if somebody asked me, what do you want in your smartphone? Wouldn't it be better at the very beginning when they are devising the new i11 phone or something like that? It's the same with the community. If you want to affect population health, if you want to affect community health, then it shouldn't just be at the end. Community should be consulted at the very beginning, even basic science, even people who are just in their labs, creating the new ways in which we look at things, or discovering new ways in which our body works. At that point, if you have the idea of what I am looking for, then your thought process is going to be informed by that ultimate objective. And that's what community engagement is. That's why the idea coming from the Institute of, coming from the Institute of Medicine is that community engagement, this consultation or engagement of the community we want to serve, should start at the very beginning and not be left to the end when basically the phone is already done and sorry, we cannot add your feature, or adding that feature is going to mean a big other thing that has to be done. That's the idea of community engagement, that it has to happen from the beginning. And that's why when I show you those scientists at CDC, it starts with their mindset. It starts with you thinking, not necessarily how, not necessarily say, I'm going to change my ways, but I am going to put my ways or use my ways with this mindset that the ultimate prize is population health and the community. Any comments or questions? Let me show you a few things that I sort of just went right past. So basically, the problem is, and I can tell you this because I did come to the United States 30 years ago because this was the best country in the world for science. And it is true. However, it's this richness and such tremendous knowledge does not translate into health for everybody in the United States. And it really is painful to see how the United States, when the industrialized countries of the world are ranked according to their health status, the United States is nowhere near the top, but it is in the lower levels. Why? Because there is not equal access for everybody, isn't it? With that in mind, that's what actually was the big engine behind the translational science program. The fact that we have the best science, but it's not being translated into population health. And this is a simple concept, but actually very visionary for the people who decided we're going to do something, we're going to change the way science is dealt with in the United States. It used to be that this is my hypothesis, this is my team of people, this is my university, and I'm not going to share anything with anyone. Where now science has to be collaborative. You all need to learn to ask and collaborate with other people so that your ideas and your science is much more powerful than if you keep it to yourselves. So, as I said, the United States does not rank first among industrialized countries as to the health of the population. And when the CTSA, when the translational science paradigm was created, this idea of community engagement was at the very core. So it said scientists need to interact with their communities. Communities have to help scientists to do their job, because if you have a clinical trial for a new therapy and nobody is participating, you are basically screwed. Because the best science still needs patients to come into clinical trials. You need participants in your studies. And so the shift, and this is very important, is in return for communities' participations, the CTSAs will help to deliver improved medical care to the whole population. So this is not a secret. That's the ultimate goal of translational science, to actually change population health. Now, this is UAB. Look at the 5 goals of the CCTS at UAB. The idea of human health as the ultimate value of your work. And then look at the second one, engage the population in studies of therapeutic interventions to improve population health. Then the other two are not specific to community engagement. But the last one, that's where you can come into place. So not everybody is going to be a public health person here. Not necessarily you have to be, out there in the trenches helping people get vaccinated or things of that sort. But you, as scientists, can help to engage the people we serve in understanding and generation of new knowledge. Very simple exercise for you. If you are, if you have to go to a church in an underserved community, could you explain what you do? Could you explain what your science is? What's the objective of your work? I'm sure you can explain it very nicely in a conference, isn't it? But could you change it? So, and this is not dumbing things down. This is simply coming to the core and saying, what words can I use to explain people about DNA, about RNA, about what I do in my lab? And I have had to do that recently because I had to create an informed consent document about a genomics study that we're hoping to get funded pretty soon. And I had to explain what's going to be done with the blood cells, the lymphocytes that we're asking them to give us a sample for. And it really tests your understanding of the science because you have to say what's going to happen. It's true, this is what we want to do with your cells, but you have to say it in a way in which people will understand. You don't have to lie, you just have to find the words that will explain people what your science is. And so I would say as translational scientists, that's something that you can do. That's something that if you strive, you can help do the last of these goals, just by thinking, how can I contribute to other people's understanding of what I do, people who are not scientists. And you would be, fulfilling one of the goals of the CCTS. Now, as I said, we have a mandate. This is the Institute of Medicine in 2013. It gave, as you know, the Institute of Medicine is sort of the Bible when it comes to science. What they do are very considerate deliberations, and then they provide guidelines that actually shape science and medicine in many ways. And they gave us that recommendation of ensure community engagement in all phases of research. So how can these people, how can communities that are not trained as scientists actually tell you something that's of value to your science? Do you think that's possible? How come? Any examples?
They can communicate their needs, and this can decide what to do.
If they tell you exactly what they need, like if I say, I need my phone only to ping when my husband and my kids are sending me texts. Isn't that simple? If they could tell you that, then you would know what to do. So then you would know where to direct your efforts. So they can tell you what the needs are. Any other way in which they can help you?
Kind of similarly, they could tell you about side effects or challenges of particular treatment recommendations, and you can alter or adapt or improve therapeutics or treatment programs in some way.
Exactly. Our science is sort of, it just follows the rules, what works best in the laboratory. but it might not work that way in real life. And so if they can tell you, you better, think about this, or I wouldn't take that medicine because it's doing this, this, and that to me, or, I really cannot come to your office for this treatment 5 times a week. That helps you, isn't it? Shape to real world needs. So that's the reason why it is so strong, this idea that we now need to really converse with the people that we're trying to serve and understand what their needs are so that our science can be tailored to that. Any comments?
Yeah, I think another is priorities. What we may think is important and interesting and a priority may not be the same for the community. I mean, we may want to, prolong life or cure, but the community may want something different. So
Yeah.
the assumption that our understanding of what a priority is may be different.
That is so true. So we are concerned with, for example, obesity and perhaps a major drug that can help us feel skinny. But the truth of the matter is, in the communities where there is no light for people to go out, where it is unsafe for people to go walk, I mean, does it make sense to invest millions of dollars pursuing that skinny pill when those millions of dollars could be invested in getting parks and safe places for people to walk? And those are the kinds of things, I don't have the answer to that, but those are the kinds of questions that we as scientists have always sort of let slide by. Science is so interesting. Medicine, biology, nursing are just enormous, how do you say, they are truly beautiful sciences that you can get immersed in them and, be very, feel very fulfilled in your intellect. However, these simple questions of what makes more sense, to invest in the skinny pill or to invest in parks and lighting for people to go out, or in safe places for people to walk. Those kinds of questions are the questions that we have to ask of ourselves if we're thinking of the ultimate value of what we're doing. And that's all that a translational science has to do, to really ask for the value of what we are doing and how do we get to that value. Okay, let me show you a few things about community engagement. Okay, now this seems like a child's drawing, doesn't it? It has a heart in the middle. But the people who created this drawing were actually a group of high-level translational scientists who got together in many workshops and discussed an issue. If you look at the source for this drawing, is the Clinical and Translational Science Award Key Function Committee, the workshop that was titled Researchers and Their Communities, the Challenge of Meaningful Community Engagement. So if you look at this drawing, what it does, it has 3 circles: the medical practitioners, the clinicians, the public, the community, and the academic researchers, in a sense, you. And it is a very simple, Venn diagram where at the intersection of these 3 things, that's what community engagement is. To me, it was very interesting that they chose to put a heart there. They could have simply, just as a regular Venn diagram, just shade that part and say, this is where the 3 things get together. This is what we are getting at. The collaboration or the interface between the public, the medical practitioners, and the academic researchers. But they chose to put a heart there. What do you think that heart means instead of just shading? Why would they put a heart? I mean, this actually, to me, looks like a child's. Why would they put a heart?
I would say at the center of all of these things, I mean, the heart of what we're trying to do is to, help people from the community. So that's how I would say.
So you would use the heart as the core. This is the core of what we want to do. The interface between science, clinical, and public. That's the core of community engagement, isn't it? Anybody else? Why did they put the heart there?
Because that's what we care about.
Excuse me?
That's what we feel that they care about. That's the community engagement that they care about to bring the outcomes to the community. And that's what they're doing.
So there was a level of emotional attachment. So the caring about. Caring about means it's a feeling. It's not necessarily an intellectual thing. Yeah. Well, to tell you the truth, I still don't like this one. I don't like it because, to me, it makes something look childish that is actually very, very important. I think as scientists, perhaps, we would react more, we would respect more, or we would be more attuned to a very, intellectual diagram. However, I do see its value, and I do agree with you too. It is a way to say this is the center, this is the core. It also gives out this idea that we have to care about it. We have to care about it enough to make it an important thing for us as scientists. However, the one thing that to me this represents is that when you, when I go to the community, I don't necessarily need to bring my brain. I do need to bring my heart. In that we are so different. I mean, I have sat in, I tell you one experience. So we, as a group of faculty members at the University of South Alabama, established a partnership with a group that's called the Bay Area Women Coalition, and I'm going to tell you more about that. What we wanted to do was, they had asked us to do a survey, a health survey of their community, and the people that were members of the Bay Area Women Coalition, they were going to do the survey. So we were going to help them develop the survey and train them to conduct the survey. So we go, first of all, we have to go at 6, not 8 to 5. And we meet in a room with the volunteers, the people in the Bay Area Women Coalition, and of course we say, okay, let's go around the room and see who is here. So we started going through the room, and nobody, the volunteers, what were they telling us about? They were telling us about what they wear, the teachers, workers in the hospital. They told us about how many kids they had. They told us how many times they had been divorced. Not what we discuss when we are in meetings, isn't it? So if we as academics would have said, oh my goodness, this is taking too long. Why do I care, these people, how many times they've been divorced, how many kids they had? If we had said that, that was doomed for that partnership, wasn't it? So we had to connect at that heart level. So when the academics started, when they started to say, no, none of them said, oh, I am a professor in sociology, social work. They also said, one thing that actually was said many times that day in that room was, I was raised in poverty too, but I didn't know I was poor. Because when people came, they spoke of the richness of their lives. They were not speaking about how bad they were or, whether they couldn't pay bills or whatever. They were giving us their life story. And as academicians, we also spoke of our life story. I explained to them about, my husband, my kids, because we connected at that level. I don't know if you ever have an experience like that, but I think coming to the community, you are a scientist, you have to bring your intellect, but you also have to bring heart. And that's what actually makes people connect in those meetings. But to this date, I would want to ask the people who created that diagram why they did it that way. But I think it does have some messages, isn't it, within it. So at the end of the day, what is community engagement? Look at what they say, and this is the CCTS workforce group that devised this diagram. They say various stakeholders, of which you are just one set, with the purpose of improving health. Now, this comes from a manual that has been created by the CCTS and published by HRSA, the Principles of Community Engagement. So what's community engagement? Collaboration, groups of people affected by the disease or the entity that you are studying, and collaboration that actually affects the well-being of people. So that ultimate value of population health is always very important in community engagement. Who is the community? And again, here you have your choice. And not necessarily all of you are going to be down in the trenches in the underserved communities, but you can pick your group. If you are interested, like you say, the curiosity of discovery, you may relate to the patients that are affected by whatever your scientific interest is. Other groups, when we are thinking, for example, of the healthcare associated infections, perhaps your community are other professionals that are interested in preventing healthcare associated infections, which is a big community too. So you can choose your community. It's just that you need to, again, think that I am not doing this on my own, and I am not doing this just for me. I am doing it for someone else that's going to be affected by my work. And I wanted to show you this example, and after that we'll stop for a minute. Perhaps the AIDS epidemic, what happened there was the most clear example of what community engagement can do. So at the start of the AIDS epidemic, and this is a very simple timeline, this is in no way describes the richness of this process, but the key points. In 1981, the first report of 6 cases of AIDS. 3 years later, the virus was discovered. 1 year later, we had found a way to test the blood supply. 2 years later, the first drug made available. In 1990, this kid who was a person who suffered from hemophilia and had AIDS because of a blood transfusion, his mother was a tremendous soldier in that she fought for the rights of people like her son. At that time, they did not want children with AIDS to go to school. because they were afraid of transmission and issues of that kind. His mother had a tremendous weight in making it public, in fighting, in really making this issue of how to treat kids with HIV, with AIDS, to the point that in 1990, while this kid was still alive, a legislation was created that actually helped to pay for treatment of people with AIDS. And that is something that we still have. Our AIDS patient, our HIV, persons living with HIV now can be helped through this legislative act. And then only 5 years after that, the beginnings of highly active antiretroviral therapy were set, the foundations were set, and now we can say that HIV is a chronic disease, no longer that death sentence that it was. How come this happened? Because of community engagement. So luckily, many of people affected with AIDS were highly educated people, people who could have means and ways in which they could influence policy, in which they could influence public opinion, and highly activated patients that actually ran clinical trials, made people participate in clinical trials, reported side effects, reported what was working, what wasn't working, and actually science advanced in the care of in the discovery and treatment of HIV at a lightning pace. Why? Because activated patients. But not only activated patients, because of a mother who wanted her kid to have, to just be a kid, to just have everything that other kids had and not be put aside as something strange or different or something that, was different. This is the prime example of community engagement. Now, the communities that we engage, the underserved communities, don't have that tremendous capacity, but they do have people who are extremely bright, who are extremely powerful in the way they can connect with legislators or with their local political leaders, and can actually help move science in the same way that the science of HIV was moved forward by community engagement. So let's just stop here for 5 minutes, and 5 minutes is enough for you? Okay, and then we'll come back, okay?
Do you have names of people here at UAB who sort of work in community engagement specifically?
in the College of Public Health,
Uh-huh.
in the area of environmental science, there is a professor that I work with that actually runs what's called One Community, which is a set of projects with community members in Bermuda.
Okay.
I can give you her contact because I'm sure she would be happy to.
Yeah, because I have a project that, we're applying for CDC funding. It was a BAA looking at prevalence of soil transmitted elements in rural communities. And so the Black Belt, this poor county that we've targeted Wilcox County as our site of study because there's a suggestion that hookworm is still endemic in the area. So the CDC wants to fund a study to truly document the prevalence because the last study done properly was in the 50s. It's just been neglected since then. But so a key component of that they told us that would promote our success in securing the funding is if we have involvement of a behavioral scientist or somebody who's experienced at community engagement, because the challenge of doing a project like this is participation. I mean, we can't document prevalence if nobody is going to participate and give us samples.
You know what? Then the person to contact is Dr. Mona Fuad. Do you know her at all?
No.
Dr. Fuad is a very strong researcher in the area of cancer.
Okay.
And I know that she has done something that's called patient navigators in those rural areas. I am not too sure about Wilcox County, but probably.
Okay.
And so she would have already people on the ground that know the community and that could help you with participation.
That would be great. Let me just read it.
She's here at UAB. What? That's UAB. And her first name is Mona, M-O-N-A. She's big in her disparities, translational.
So School of Public Health?
No, she's actually in the College of Medicine.
Oh, College of Medicine.
Yeah. I know you'll find her email easily for her.
Yeah, so she must have a UAB MC, I would imagine.
Yeah, probably.
Okay.
Look her up. Yes, because she does have contacts in that area. She has she's done so much with cancer prevention, screening and all that, but she's done it because she has people from the community serving as navigators, so they could help introduce you to people or help themselves. Because these are people from the community, they live there.
Because again, it's to try and align, what the CDC wants to do, right, with what's important to the community and make sure that it meets in the middle.
There is always some bias to the community.
Yeah, if it's done in the right way. Yeah,
Exactly.
and this is a particularly challenging one because sort of in the 2000s, the public health department was finding and imprisoning people from the community who had inadequate funding. And so the reason it's a problem is because of poor funding. And so there was not a good method of addressing the problem, right? And so it's just sort of made the community very distrustful. Yeah. So that's going to be the biggest challenge, I think, for us to do this. Yeah, submission is urban. Yeah, we already have a community partner, so I have a lady who's health who did a thesis for her MPH in Wilcox County. and have established a relationship with people within World Cup.
Right now.
And at that time, she had looked at culture, she was doing a child review of children as medical records and found that so many children were being treated for work. But hers was a needs assessment of World Cup, so she looked at many other things in addition, and has sort of maintained a relationship with the community leaders on the ground. So that's why we targeted World Cups, because of that relationship. But certainly if there are other people who have worked in this area, just to, because she has a relationship with one person who has a private school community center that services maybe 200 children. We're hoping to reach the whole community. So maybe to expand beyond her contact. So that's why I was just wondering if you had any.
Well, it's actually 5 years. I know probably. And another strategy is to just say that, for this initial course, you will engage other. I mean,
and that needs to be brought in on separate days, and they have to be brought in within 18 hours. So it requires a high level of motivation, right, to bring the school sample and do it within a timely fashion and do it on 3 sequential days. That's why I suppose people have to tackle these projects, because it's hard to do. Well, so we're going to look at, do people want us coming to their homes, right? Because again, in the past, public health officials have come by and fined everybody and put them in jail. So do they really want people coming looking at their homes? I don't know. And then, the school system there is also, they've been through about, I don't know, every couple of months, a new school superintendent comes to one of these failing schools. So, going through the school system, does that work? I don't know. There's lots of problems in accessing the community because of things that have happened in the past that I don't blame people being distrustful by. So, but the United Nations, like 2011, did like a mini so it was for access to clean water, and they came and toured the United States, and they actually highlighted, Belt, Alabama as being really in a very, very poor state of access to clean water, and so it's been highlighted in the press, and the Congresswoman of the county is very interested in supporting our project. But again, is she pro-life? Maybe I don't know. Yeah, if she knows who would be good partners to sort of ask, how can we structure this in a way that would really align with what the community would want to have. Good. I was so happy with watching this whole today's talk.
Okay. Okay, we are going to continue. Let's done that. Okay. So I just wanted to show you the CTSS, the Center for Translational Science, formally were launched in 2006. So there are 62 centers, of which UAB is one of those, and they were funded with the mandate of, aside from changing the paradigm of science from being one of my hypotheses, my team, my university, to the paradigm of collaboration, of actual partnerships within academic institutions, where no longer a hypothesis is valid just because it's my hypothesis, but also can be enriched or enhanced by having been discussed among groups of scientists from different disciplines and from different academic settings. That's, as I said, a big change in paradigm. Well, because the Translational Science Awards have this mandate of community engagement, all 62 CCTSs around the United States have to think of community engagement. It's their mandate. So new ideas are coming through. And of course, of these 62 institutions, some of them already had a good starting point of community engagement. And the mandate and the money from CTSA helped them build from what they had. Other institutions had to start from zero. They had never thought of community engagement, and they had to start from zero. So at this point, the growth or the maturation of this idea of community engagement as an important component of translational science is in diverse stages. The institutions that already have a foundation of community engagement have built and created more, and they are sort of a step ahead in this maturation process. Institutions that have started from zero are finding their way. This is not an easy thing to do. And so what is striking to me is that now when I prepare for this talk, which I have given for the past 3 years here at UAB, I find more and more in the literature that tells me, that shows that maturation is happening. So there is more science behind community engagement. And I want to show you a few things that people are putting forward when it comes to community engagement. So look at this accelerator model. And I think that's what happened with HIV. There was the right view of community, industry, advocacy, public health that actually made that timeline be so fast, so achieve so much. But now the CTSAs can choose sort of from different models. So this accelerator model has a few important ideas. So if you put together the researcher, you, with a clinician, some of you, with patient advocates, which was what happened in HIV, an interested funder, the CCTS, people who know about public health and policy, and industry, which is so important because industry basically is the gateway, the gatekeeper to treatment, to affordability of actual therapies. If you put them all together and with a real desire to find new ways, things happen. And leaps and bounds of progress can occur when you put all these diverse constituencies together to evaluate the program. So, as I said, I believe that was what happened with HIV that made it progress so fast. Now, what does community engagement look like? So, this is a question for you as members of a translational science institution. But it's also an important question for the institution itself. So we've said, didn't it say in the vision and mission that we want the UAB CCTS is going to be focused on metabolic diseases, cardiovascular disease, cancer. And it says that its area of influence is going to be the region, and ultimately we want to eliminate health disparities, isn't it? Those are lofty goals. Well, the institution has to make a decision. So who's going to be our community and how close do we want to be? So community engagement can be sort of, mild, moderate, or severe. in that, mild, you just send out, let's say health fairs, you participate in health fairs, you create some educational materials and send them out to the churches or to any institution that is trying to look at health issues. You are community engaged, but this is very, uh, mild level of community engagement. Um, you can consult the community. This has been done many times with church leaders, for example. So you go and say, we want to actually impact diabetes or cardiometabolic disease. Um, how can we do that? And leaders will tell you, you could do this, you could do that, and that's your level of engagement. Now it starts getting more interesting, but also more commitment if you actually involve these people. Okay, you go to your church leader, this is what we can do. Okay, let's do it together. And then when you start bringing the community to be a real collaborator, so community members sit in meetings that are important for the CCTS. And finally, when you let the community have its voice and actually become a real partner in your work. So those are the levels of community engagement. Again, definition, well, I think we've done this one. Let's go. Okay. Now, there is something that's called community-based participatory research. This is community engagement in steroids. So this is specific for researchers. This is a process in which a researcher actually goes to the community and just like you had said in the past, we get our funding, we get our interest as scientists, and we want to go and engage with the community to do what we want. Well, participatory research is when you go to the community and say, I am a scientist, this is what I do. Is that helpful to you? And you have to be willing to hear the word no. It's not helpful to me. Okay, what's helpful to you? This is what we need. And then you use your science, your knowledge, your capacity, the tremendous resources of the university to do what the community wants to do. And to tell you the truth, they have very good ideas because they are anchored in the reality. They are trying to survive. I mean, when you're trying to survive, you have a clear mind. You know exactly what you need to do. And so, for example, once we came to our community and said, okay, there's money for doing research. What do you want to do? The only specification was it has to be a policy issue. It is a health policy issue. We have to research a health policy issue. So what do you want to do? They came with two interesting ideas. One was we need to show that nurse practitioners, usually they have a limit of how many Medicaid patients they can have. So there is some sort of regulation or limitation that says a nurse practitioner can only see this many Medicaid patients, where a physician can see more than that. Let's say, I'm not telling you the exact numbers, but let's say a nurse practitioner can have in her panel of patients 500 Medicaid patients, where a physician can have 850. Okay? So they say we need to show that actually the nurse practitioners have much more capacity than physicians. And we need to change the legislation so that the nurse practitioners can have at least 850 like physicians, or even more if we find some way in which that could be worked out. Don't you think that's an excellent idea? The other person that we consulted said, in disadvantaged communities, many people don't have titles to their homes. They just pass them around from mom, grandmom to the daughter that stayed, or the husband, or the son who was married and brought the kids. So what happens with that is, because they don't have titles, they cannot apply for support, for example, to create better plumbing or to restore after a hurricane, and so on and so forth. So an important policy issue is to help these people get their titles. Interesting idea, isn't it? So what I'm telling you is, don't be afraid to ask the community for research ideas, because they will have them. Now, not all the time we can match perfectly the funding that is out there with community needs, but at least we can ask them to come with ideas that will match our funding. The world is not perfect, and usually funding is given with some specific interests or scientific areas that need to be covered. But if you ask the community, they will come back to you and they will bring really interesting ideas. So this idea of community-based participatory research is that idea of investigators actually going to the community and doing the work that the community wants in a research way. That's community-based participatory research. And that sort of shows you the progression to that. You cannot start at the end, really. A community has been many times tapped and researched and never given anything back. So for community engagement, you really need to stay there, to be there for a long time, to show that you really mean what you say, and you are not just going to go away after the funding is gone. That's why I say it's the institution, really. When they say, we're going to do everything to make your work, to help you do your research, that's one of the things the institution has to do, has to create structures that will connect with the community in a long-term basis and not on an ad hoc basis. So it goes in stages. It doesn't happen, one time and you are a perfect, community-based participatory research person. No, there have to be structures that have been created and sustained and maintained to get to that point. Okay, this is another interesting graph. That's again just coming in the literature. I think this is a 2016 article. Look at the bottom. You have your T1, T2, T3, T4. That's translational research stages. But it's not isolated. There is a whole context to this. So basically, you are some point in here, but you cannot forget the overall picture. And what's the overall picture? Well, you have the environmental, socio-ecological model of health, in which your patient, the individual, is embedded into several structures: the family, the community, the socio-political environment. All of this has a context of culture, of issues of power, racism, social determinants of health, history. And that's the kind of entity community engagement is tapping. So I really like this diagram, in which it puts the translational researcher still, at the level of translational research, but it reminds us that it all is part of a big context. And that's your challenge, actually, as translational researchers, to understand that you are not in a vacuum. Your science to be really valuable has to also acknowledge the whole context. And this doesn't mean I am asking you to be, advocates or politically oriented. I'm asking you to understand that you are part of the system and that what you do will influence the system anyway, either way. And if you want to influence it to give value, the population health value, then you need to move, to think in that direction. It's just a mindset at this point for you. The institution has to create the structures to make this happen. But remember, one day you are going to be the chairman, you are going to be the head of the department, and so you will have more power than you have now to actually move and create the structures where science can actually address all of this context. This is another one, and this I think is, let me see, this is 2013. Of course, there is a lot in here, but basically the idea of community engagement, you look at inputs, short-term results, intermediate results, long-term results. Look at the long-term results. Better science, better answers. Because your work is going to be motivated or be aligned to that population health ultimate value. And here in those three circles, at the beginning, that's what the CTSA has to do. Those are the structures or the supports that the CTSA has to provide you with. In the middle is what will make this be truly successful, and it is creating the frameworks that are going to help you do your work. So this bi-directional consultation with community, the actual partnerships that are going to help you do your work, all of that has to be created by the entity itself, by the CTSA. At the end, look at the title, Altered Research. Altered research doesn't sound too good, but what is being altered is the mindset. So again, this idea that our science has to address the communities, change academics. So academics view community engagement as a value to them. Teams do science, multidisciplinary teams. The workforce also is more diverse, and all of this means that the community is more engaged in your research, and your research is more valuable to the community. So as I said, the fact that now we have diagrams that actually explain and expand on this idea of community engagement is a sign that we are maturing in this concept. All of this is work in progress, but it's work that's being done. Okay, and just a few ideas, because as I said, you are going to be the heads of departments, you're going to be the deans at some point. So let's see how can you support community engagement? So the very first thing is define your community. And again, it could be industry is your community, patients are your community, or it could be a geographic location. In the case of our center, we have defined our community as the 3 zip codes that are around the USA Medical Center. These are 3 zip codes that have about 90% African American, about between 20 to 40% people living under the poverty level by the census. In our community, there is only about 10% of people who have graduated from college or have another degree. So we have defined our community that way by the geography of where we are located. The next thing is learn the etiquette of community engagement. And a little bit of that is, first of all, etiquette means respect, isn't it? We think, I don't know, but sometimes because of the way we have had our education, we sort of think that we know it all. And when you go to the community, you cannot go with that mindset. In fact, they are experts on survival. They can teach us a few things. So you have to go to treat them as equals, and perhaps change a little bit your ways to understand their ways. It's important that community engaged researchers are around you, that they can guide you, that they know what they are doing. Recognizing that your science will have to be tailored to what can be done to respond to community interests and still be scientifically valid, but you might have to change a few of your methodologies. And always, and this is something that we have not been known for, we do our research in the community and we publish in our journals, and the community doesn't know what happened. So dissemination is, again, another big important component. And luckily now, we know that we have to give back the data to the community in ways in which are appropriate to them. And that's being recognized as one professional responsibility of research. Now, so these are just 5 guidelines. If you are ever more interested, there's many articles that can expound on these things. But the one important thing is it takes time. As I said, you as investigators can get your partners in the community, and those partners are going to add to the pool of partnerships that UAB might have. But at the end of the day, it's responsibility of UAB to maintain and sustain those partnerships, because let's say you do this beautiful project in the community, and then you are tapped to go as head of the department in Colorado University. You lose all that value if it's just all that community engagement value. If it is just based on the individual faculty, it's going to be lost. The institution has to make a commitment to support, sustain, and grow those partnerships. You can be the agents, but there has to be a structure to support it. It takes time. It cannot happen in a minute. You have to be there for the long run. And just as the last part of this presentation, I wanted to tell you some of my experience of community engagement. And I've already told you about my partners, the Bay Area Women Coalition. The Bay Area Women Coalition at this point are 3 women. There used to be more. But they are interested in the development of their neighborhood, which is the Trinity Gardens community. These are my 3 partners, Ms. Ella Irwin, Ms. Yvonne Fisher, and Ms. Salome Wiley. Their community is an impoverished community. They go, it's about 3,000 residents. I told you our zip codes are 3610, 3617, and 36603. This neighborhood is in those 2 zip codes. African American, only about a third high school graduates, a lot of unemployment. People who are not in the labor force, they are either, they have some sort of disability. and a big proportion below the poverty line. I am part of a group which is called the Health Disparities Research Group, which is academics from the University of South Alabama. And the Bay Area Women's Coalition is a formal 501c institution. Okay. This is their accomplishments. And this is, I mean, I could write 3-4 slides with their accomplishments. They were founded in 1997. Their very first job was to rid their community of drug laws. It was rampant. There were shootings. It was just terrible. So that's what they did. You know what they did, these women? They saw that the drug trade was happening in the streets, but nobody was taking pictures to show the police. So what they did is they went with, how do you call them, baby strollers, and they hid their cameras in the baby strollers, and when they saw something happening, they would like take the kid and take the picture. And the FBI got those pictures. They ran the drug lords from the neighborhood. I mean, couldn't we learn something from these people? They got some funding for the Weed and Seed program to continue the idea of policing their neighborhood, of not getting the drug trade to be so rampant in their neighborhood. And they actually, there was no more drug trade in Trinity Gardens. In the periphery, yes, but not in their neighborhood. They then got some grants from HUD to construct, to build new houses, and they created a senior housing development. They did cultural and educational activities. These women, the Bay Area Women's Coalition leader has a master's degree level. She was an educator. But they basically hit every nail in the workbook of how do you create or how do you do community development. Culture is an important thing. So they did leadership and education for community members, after school summer programs, created a branch of the public library in their neighborhood. They did a festival, you know, a Mardi Gras time. They have their own Mardi Gras parade. I mean, it's like they had a workbook and they were doing everything that is supposed to be done for community development, but they did it just because they thought that's what they needed to do. And at the end, they were very concerned with bringing a clinic to their community, and that's how we got connected with them. So I don't want you to read all of this. I want to show you there is 2 slides of this, because we started working with them in 2007, and we only completed our work in 2012. There were many stop and go problems. We said we would help them with this survey of their community, but we didn't get funded for the survey. Then we said, okay, we're going to do it just as a volunteer, but then we had to get IRB. We had to get the IRB run by NIH so we could do this activity as part of our funding. All in all, it took 5 years to get to the questionnaire and the surveys that they did in their community. So the question is, you know, how did we survive? And this is the lessons that I wanted you to learn today, our lessons. How come we survive? And to tell you the truth, this partnership has been very valuable to us. I am not too sure how valuable we have been to them. But through this partnership, we got a 5-year grant to do a surveillance study in their community. And recently, as I told you, that genomics informed consent, we have a very important genomics lab at the Mitchell Cancer Institute in South Alabama. There is a premier, nationally known genetics basic science researcher there, who had created a method in which he can evaluate, let's say, that same method on regular basis could analyze, let's say, 90 samples. He improved it so that it could analyze like 300 samples. And now he wants to make it, he wants to continue improving it to analyze like 800 samples. So this is what is called a high throughput method of genomic analysis. And he is well known for that. Well, there was an RFA that requested a genomic analysis methods for population-based studies. And he's a lab person. He didn't know anybody in the community, but he had a dinner with my boss, Dr. Errol Crook. And so he said, I have this problem. Do you know of anyone who can help me get to the community? And Dr. Crook said, that's what we do. And so we wrote the grant with them because we could guarantee that we will have access to the community. One of those guarantees is our partnership with the Bay Area Women's Coalition. At this point, that grant is the second one among everybody who was evaluated. So we are expecting to be funded. And that is because of our partnership with them. So as I said, we've gained. We are still in the process of helping them get their own funding, and we will continue to do that, to do so. But it's been very valuable to us. So what I want to show you, the last thing in this presentation, is how come we were able to sustain this partnership. Without money, remember, we weren't funded, with just our commitment to stay with them. So the very first thing is this idea of respect. And I didn't know it, but when we first met them, I said, let's go to their office. I never expected them to come to my office because it's my interest. I want to write the grant. I go to them, Well, they saw that as important, that we were not asking them to come to us, but that we came to them. And the second thing that they say is we listen to them. We weren't saying we have all the answers, but we listened to what they had to tell us about the project that we wanted to do. So those are important. The other idea was, okay, what do you want to do? There is this money, what do you want to do? And they have been studied many times, never heard or understood why. And so they say, when we can tell the research hypothesis, that's more important for us. I have to tell you, participatory research, it does require a mindset. Not everybody can do participatory research. There are many leaders too in the community that are very politically motivated or self-motivated. And there are investigators that simply just don't have the mind frame. So in this case, we had the right mix of people. The PI that eventually took over this project was a social worker and had some experience with community, going into the community. So that was an important thing for our project. But I think the most important thing is this. So we had the same goals. On our end, we say our goal was to eliminate health disparities. That's our goal. Look at how they see it, They see it from very practical, visceral terms. This is their lives. To us, if we don't eliminate health disparities, it's not going to be a problem for me. I am an academic professor, have my insurance, But if we don't eliminate health disparities, that's their lives we're talking about. And see how they say it, We are trying to get help here for our people, and this is visceral. They don't have insurance, they don't have employment. We need social programs and mental health programs. And their ultimate goal was that clinic. So we got a lot of sick people here. We could justify a clinic. So they saw some value in working with us. Look at what they say, $20. I mean, there's been times in my life when $20 was a problem for me, but not anymore. For them, $20 is like, probably to say that, I would have to say something, $1,000, you know? But $20, which seems not too much, is a lot to charge for healthcare. And if we get the clinic, there will be a social worker here. We can deal with our problems. So, as I said, on my end, our mandate was to eliminate health disparities. On their end, that's what it means. That's what health disparities mean. So don't you think they would be very strong allies? Because for them, it's their life, it's survival, isn't it? That's why they came with these ideas for research that were so practical. Let's get more people, nurses to see more Medicaid patients. Let's get people to be able to have the titles to their homes. And the important things, the relationship. Remember, if we as academicians on that first meeting, we started speaking about our credentials and where do we work, that relationship wouldn't have been established. The idea of the long-term commitment and trust, because in our working together, we learn to trust them and they learn to trust us. So this doesn't happen overnight. Other things that we learn is these are sophisticated people. I mean, lack of education doesn't mean lack of intelligence. And some of these people, particularly, remember the women who took the pictures for the FBI. Don't you think that was very intelligent that they did that? And in particular, the leader, the Bayer Women's Coalition leader, is very politically savvy. She is good with everybody, any political leader of any denomination that comes to the neighborhood, she's good friends with them. Because she knows she has to have them to support the work. That's very sophisticated. I mean, I don't have that capacity. You see it in my face, about my political beliefs. But no, nobody sees it in her face. She can talk to everybody. So when you go to the community, be ready to be surprised. They will come, they truly, as I said, lack of education doesn't mean lack of intelligence. And even in very small and practical ways, sophistication is very important too for them. As I said, they are surviving. They have many, many practical tools that they can teach us. And as you said, sometimes what the university wants is not what the community wants, and you have to be aware of that. So even if the grant is for some, very technical, scientific purpose, if you can find some way to create a value for them with that money, and even, the least that you can do is to treat them with respect, not to make people feel like they are lower or lesser because they are not educated. Just that respect, if it's genuine, it will actually build the community. The communities are also not dumb. So now the communities understand that the university needs them because there is this mandate. So it's more of an equal footing. But as I said, it's important to try to find some value for them, even if your study is highly scientific or it's not what they need, but there has to be some value given back to them. And the issue of interdisciplinarity, so when you go to the community, because the problems are so varied, you need an interdisciplinary group to work with you. Any questions or comments? Okay, well, I want to give you my gift. Remember what the CTSA said at the beginning, your science should be inspiring, we can help. Well, if you think of what that woman did, if you think of what it translates into benefit for the population health, the Ryan White Act is the payer of last resort for people who don't have insurance. And my husband being in infectious diseases, he treats HIV patients that are part of the Ryan White Act. And that's how they get to have their disease control. And it wouldn't have happened if that woman wouldn't have fought for her son. So don't underestimate what the community can do for you. Okay? Well, thank you very much.